So I think it's fair to say we've been less scientific and more practical in terms of our approach and what we've done so far on this work. So we've probably got not as far as some of you in the room, but we've got tons of learning and have got great value as partners in terms of the way of working. So we're hoping that will continue with the work and with the patients that we've identified, but we're hoping that learning and that approach will translate. So that was just a precursor. And we've been we've actually used more of our local intelligence to decide who we work with. So there was a delay from Optum in terms of getting the data to us. And Cruz particularly was challenging about, well, we could go down the medical route, we could think about a condition, and the Optum data that did come said, yeah, your top issues are diabetes, mental health, depression, and COPD, respiratory. So it's like, okay, well, we knew that because we have we know what we're working with in our neighbourhood. We know it well. We know that there are a lot of the issues there. But where will we get most value? And Cruz particularly was putting in the challenge about, well, but what are the causes of those causes? What's behind all of that? And I think Cruz is fair. He'll say more in a minute. He's not just standing up to look very pretty. In terms of, I see patients day to day that live in these houses of multiple occupation in Blackpool, and that is affecting their physical and mental health, and we need to get behind that. So that's what we did. So quick guide to Blackpool. You'll all know Blackpool, seaside town, huge growth in the 19th century in terms of the working class population from our industrial towns in the northwest, particularly in terms of holiday resorts. Lovely pictures of how busy Blackpool was in those days, and it's busy sometimes at the moment. But that has resulted in lots of these now not used for B&Bs and other accommodation in terms of houses of multiple occupation, and that's just a typical example of that. And a house of multiple occupation is, by definition, somewhere where 3 or more people live that are not sort of within a household, so a family, and they share facilities like bathrooms, kitchens, and so on. So that's the definition that we're working to here. And just to give you a bit quiz, anybody want to check out how many houses of multiple occupancy are there in Blackpool? A, B, or C? How many? C? Okay. B. So just to give you an idea, so in Fylde we have 500, in Blackpool we have 4,000, and in Preston 2,500. And as was pointed out to me, in Preston that's majority student accommodation, so a very different cohort of people in Preston. So it's a huge issue for Blackpool. And that's typically what some of our enforcement officers at the council go in and see. Children and families live in those conditions, as well as our people that migrate to Blackpool to run away from something or to start a new life and so on, and it's entrenched in this area. So we know housing matters because it has huge effects on physical and mental health, so that we know that. There's tons of evidence about this, but what we're particularly focusing on in this instance is that depression and anxiety. So people come to Blackpool to start a new life. They've searched on whatever search engine they search on, and they found it's a cheap place to get accommodation. There's work, in theory. So they come and then they move into a house of multiple occupancy, and it just spirals out of control from there for many people, not for all, but for many people who often come with a sense of vulnerability anyway. And it's the housing issues that are a driver of this population movement, this transience and this turnover of people within the neighbourhood. So you can work with a cohort of people and then they move. So we generally say we import ill health and export good health. This is just to point out the neighbourhood that we're looking at within Blackpool. So this is our neighbourhood, and these are where our houses of multiple occupancy are. They do spill into another neighbourhood as well, so that's what we're looking at. It's a significant issue. And I'll pass to Cruz.
Thank you. Good morning, everybody. My name is Cruz Augustine. I'm a GP in Blackpool and a Blackpool governing board member as well. Like Liz said, I moved to Blackpool about 18 years ago on a 6 months posting as a junior doctor. And for some reason, I never left file course since then. And it's like most of the patients we see day in and out now, they just come to Blackpool, think something really good about Blackpool, and they must have had really good childhood memories. And if you have any problem or for various reasons, they think, let's move to Blackpool. And then it's just, really, it's the last place to be in Blackpool sometimes for these sort of patients. And as Liz said, we thought about which group of patients we can focus on, and rather than take a condition as a significant number of our encounters with the patients, in most of the clinical care or for social and other mental health issues, rather than just medical needs. As Liz mentioned, there's quite a lot of people living in the HMOs in our neighborhood, and this sort of accommodation, not only the mental health and the respiratory conditions like childhood asthma and a lot of ill health is raised from just for the accommodation, and also the unnecessary demand from this population on the GP service and the acute in A&E attendance is raised from this sort of population. So we just wanted to bring different stakeholders, not only the clinical teams, voluntary services, social service, and public health, to coordinate the care, and rather than working in silos, whether we can break the barriers and sit as one team, and how to manage this population, and also to get some sort of engagement from the patients. There's quite a lot of initiatives happening. Like you must have heard the Integration 2020. It's a big thing in Blackpool, where we bring different services. Police, the fire service, the public health, GP service, and the community services. So we thought of working on a similar line and try to find some sort of solution for this problem. And just going on the initial step, we couldn't get much data, as Liz said, from the Optum to identify these HMOs. So we found a way of getting this list from the Blackpool Council, the housing data of how many HMOs in the neighborhood. And then we worked with the practices to marry the postcode and the HMOs with the actual patient data. So it was a manual work, and it took quite a lot of effort. So from the first data, we got about 3,125 patients living in the HMOs among this neighborhood of 34,000. And we want to narrow down by find some sort of activity, but we thought of using the example of the GP activity. If a patient is coming to the GP practice more than 5 times, we thought we'll use as a cohort and work from that. And then as we came, still there was a significant number of patients. For example, there's one of the practice which have a population of 12,000, and they had around more than 5 GP appointments from nearly 100. It's nearly 300 patients, and then we wanted to even filter down this population by number of appointments to that GP, more than 5, and also the depression register. So they gave about 150 patients from the population of 12,000. So we got some, to have some sort of distribution among the 4 practices. We picked up about 50 from the neighborhood, and we came with the number of 41, because one practice had, we expected more, but they had only 1 from their 10 we wanted to include in this pilot. So we identified this population to work on, and then we brought together the public health, the mental health teams, and then we got the neighborhood team as well. We have a well-established neighborhood team at this moment, where we have the district nurses, matron team, the health visitors, and the voluntary services. So we thought of using this neighborhood team to address these issues. So just to give an update where we are up to now, we got the data and we just got a plan to work with this group of patients. And we just, this week we are planning to start engaging with this population. And there are a few issues came up when you visit this residence in this accommodation. It's quite a lot of, not only the patients, sometimes the other patients in their accommodation can be difficult to work with. So it was the issue of female health and well-being worker going alone into this accommodation. So we just had to find a way of getting the lone workers device and also working with the mental health, whether they can send some members to work with them. But to scale up for future, we are in the discussion with the police and the fire, and they are very keen to support this scheme, and they are just finding a way of risk stratification of this population, and maybe sending some members from their team as well to work with us. As mentioned earlier, I know this is 20 weeks. We want to achieve this within 20 weeks, but we thought this population we identified a really difficult, challenging group of population to work. So we thought we use this opportunity as a 20 weeks to bring together our different stakeholders and to progress as a the long-term process and how we can use this population management tool to sit with this neighborhood team and the newer PCNs which is going forward. I'll just hand back to Liz.
So Kate's telling me I'm running out of time, so you'll get the slides. But as I say, a lot of although we've not yet been in touch with any of those 41 patients, and we still don't know actually whether they want to get in touch with us because we need their consent and their willingness to engage. Our approach is very much about, we're thinking really carefully about who we send out with that health and wellbeing worker, because this needs to be a positive approach, not a sort of top-down, we must do to you approach. So we thought about our housing enforcement team, thought about the police. No, that sends all very negative messages. This is about patient engagement. So we're and their motivations and their willingness to engage with us and change something. So the health and wellbeing worker, absolutely trained in brief interventions, motivational interviewing, uses the PAM tool, all about action planning. What's the one thing that you would like to change, and starting small and building on that. So it's just about their engagement. So that's why we're thinking very carefully about that. But there are risks in sending a lone health and wellbeing female worker out to these houses of multiple occupation. We know there are significant issues around antisocial behaviour, drug and alcohol addiction, and mental health, severe and enduring mental health. So we're treading carefully and we're moving slowly, but we're absolutely committed to work with this cohort of patients and beyond. We'd like to do a lot more. But a lot of the learning in this is about capacity. So absolutely, we've got the leadership, we've got the willingness, we've got lots of partners wanting to engage, including council services, including housing associations, more positive together in terms of employment support, into the voluntary sector. Absolutely loads of willing and able, but there are significant capacity issues beyond, let alone the NHS capacity within other services. So we have to be alive to that when we try and when we scale this up, and if we lift and shift this to other areas. It's not just about the NHS part of the system. As we know, 80 to 90, depending on which research paper you read, is beyond the health and is beyond the care. It's about the wider determinants. So it's those parts of the systems that we need to consider within this as well. So lots of learning. The one thing that my BI and intelligence colleagues will want us to say, apart from lots of things about EMIS, that in terms of it's only as good as what's on the system, and there are lots of different codes used, and we need to best use those codes in terms of the data that we collect, is the evaluation. So we will admit openly we've not been able to do a robust evaluation because we moved perhaps too quickly and thought about evaluation too late. So we will evaluate our own input and the outputs and outcomes where possible, mainly around patient engagement, so the softer side of things. And we'll hopefully do some of that impact on the NHS in terms of demand on services. But we need to think about that more cleverly, I think, before we start. So our random sample wasn't terribly random, so how can you compare apples and pears? So I'll just say that because Kate is saying enough. Liz, thank you. Is that on?